and I take forward from the Dr. Pradeep what he said, that the LASIK, Keratom and LASIK was the thing when we were doing the LASIK surgery as a startup. Now the things are moving beyond the flaps. So here we are coming for the Keratorefractive lenticular extraction, why we do it and where we stand. The main purpose of that, it is not the LASIK is having full of complications, but definitely there was some complications with the flap which we faced and you all must have faced, and these flap related complications are not in your hand. They are depending on the size, the place and the patient cooperation also. So here I am going to share you my experience with the low energy lenticular extraction. I am using Zeiss Visumax. Initially I was using 500, now I am using 800, that is a Smile Pro machine. Other machines I have not used personally, but I know from the friends and other people that they are also doing good. But the basic thing is that we have shifted in the LASIK surgery from the place where we were doing something like surface or LASIK, and now the surface and LASIK means no flap is there, and because of this there are different advantages, and these advantages are not only in the cosmesis or the surgeon comfort, but these are giving a definite advantage particularly for the post-op patients. I personally had a patient with the LASIK in which he had a trauma when something was moving like this, as if someone was hitting with a stick and the flap has gone away and there is no flap left over. And I am seeing that lucky there was no perforation in the cornea, but the flap is nowhere available, and these kind of things can happen, but this kind of things cannot happen in the Smile. The similar way, we had a patient who met an accident while he was doing water sports, and he was post Smile. So luckily he had a big trauma, the corneal tear was there, but everything was otherwise maintained and we could repair the tear and maintain the good vision because there was no flap and the flap related complications like the wrinkles and other things and epithelial growth which can happen with the flap. So it is not the example and reason that we are doing, but we actually doing it for the reason that personally we have found that the patients are getting better vision also because it maintains the prolate shape which is not there in the LASIK. Maybe the reasons are that we are different kind of flaps. Like you said very correctly, the meniscus flap were there initially, which was one way advantage that the flap were thinner in the center, so you were getting more residual stroma to ablate upon. But in lenticular extraction we are actually making a planar flaps. Now there are some machines which are not making planar flaps, they are making some different kind of flaps, but I still feel that optically if you consider these kind of planar flaps gives minimal aberrations, and that is the reason that I still choose and use this Smile, for the reason because it is giving a lenticule which is plano on the anterior surface and having a convexity on the posterior surface which gets submerged with the cornea because of the corneal pressures and does not induce aberrations. As well as the bigger advantage that even with a 6 mm optical zone almost nobody is getting a glare which was there with the LASIK, because the LASIK 6 mm optical zone was not giving the exact optical zone, but it was reduced than that. And with these kind of procedures we are getting better thing. So here I am just showing a scouting diagram. You can see that this part is basically a plano which is remain as a cap, and this part which is grey and outlined by the red is removed from the center, and the opening can be reduced to 2 mm. There are different kind of profiles. When you say biconvex, actually you have to cut little deeper to reach into it, and when you have biconvexity you actually weaken the stroma much more than required. Anyway, there are different kind of things and different principles, but basically the platform which are doing lenticular extraction are going to survive. There are many companies are there, so that is a big advantage. When we were alone, means one company was making and there are very few surgeons, so it was opposed by all, but now it is adopted by all, and I think future will be a flapless surgery, and it is not similar like a surface ablation. It will be a different, because surface ablation have different disadvantage based on the reason that the healing is there, and whenever there is a healing in the corneal tissue you can't control. Some patients develop a haze which is not significant, negligible kind of haze, but there are few patients who develop haze which is significant, affecting the quality of vision and causing the regression into the number. So surface ablation is not very well controlled in your hand for the healing purpose, but when you do LASIK or you do a lenticular extraction, the healing is minimum and it is controlled, and it is almost same in all patients. Very few patients have some extra kind of healing things which can be managed simply, but in surface ablation there are some limitation. The advantage of surface ablation is that you don't require many of the equipments and the cost is not increasing except the exam laser. Here I am just going to show a complete surgery how it actually goes. एक मिनट, माउस नहीं आ रहा है इस पे,
नीचे है सर, नीचे।
अच्छा वहाँ दिख रहा है, अच्छा सॉरी। कंट्रोल F L। ठीक, thank you. So this is the actual real-time surgery in which we are doing, and this is 8-second laser. We are cutting the posterior surface, and now we are going to cut the anterior surface of the lenticule, and this can be removed through 2 mm. This machine, now we are having automatic shifting of the surgical part and the removal microscope, and this microscope comes on its own, and then we have to do a dissection. Dissection is really very smooth, and it is going just like a cakewalk, and you have to be very cautious that you should not have a forceful movement, otherwise you can actually do damage to the flap or cap. So this can be removed this way simply. And the biggest advantage I found that this is very smooth, and the biggest advantage, as I was showing the topography, you can see the pre-op topography and the post-op topography. So because of this kind of smoothness in the topography, the patient quality vision is very good. And here you can see the flap and what is the area we have done. And now we are having a machine in which it is linked with the AIOS 700 for the cyclotorsion part, and with this the results have further increased. Though we were not thinking and having many of the patients who are having issues with the astigmatic treatment, but now we have treated up to 4.5 diopter astigmatic, and the patient's treatment is very good. And these are the things, how the picture comes, and then you can treat. And in this video, just to demonstrate you, you are docked, and then the machine gives you cyclotorsion part, and then the treatment can be done. And this is the way you can do, and there is a central line in which you know the visual axis, and you can actually annihilate exactly on that. So this is giving a better quality of vision, not having a decentrations. So these are the things which are improving. I am just sharing my experience that small incision lenticular extraction is possible, and you can do just 2 mm, because there is a limitation up to 2 mm. You can't go less than 2 mm by the machine. But I think going beyond, maybe having some kind of heroic surgery, so it is better to be on safe side and use 2 mm only. It gives a very precise shaped corneal lenticule, which is not changing with the patient cooperation. There is no kind of decentration because eye is under hold when you are doing treatment. And treatment can be done almost 8 to 10 seconds as a ablation time, and myopia up to 12 diopter can be done. Hyperopia is into consideration, is done in a study, approved, but not with the commercial launch, at least in India. And custom treatments like you can do with the excimer and abrasions is not, you cannot correct. But what we have done is study, our study is showing very good results. So there is a good advantage of these kind of things which I am not going to share. And this is the silk or J&J Elita, but what could I get the pictures from somebody, the dissection is not that smooth. The Schwinn is also come, and they are saying that we are going to treat something differently and making a shapes little better. And the similar way the Gmer is also there. So there are different machines which are there, and I feel with the time these kind of things which are going to do a lenticular extraction will survive. And it is not against LASIK or surface ablation, but with the personal experience I feel the surgeon comfort and surgeon safety is increasing with the use of femtosecond laser. It is there in other specialty also, but it comes with a big cost, which is a big challenge, that how many people can actually afford it. But if cost is not the issue, I will go for that kind of surgery, which is a lenticular extraction. Thank you for this time and opportunity. I will be happy to answer if you have any questions. Okay, tissue per diopter is almost the same, little more than new kind of laser profiles like we use MEL 90, little more than that. But if you compare the other examiners which are having little more tissue exhibition, it is almost the same.
So for low myopia it will take more tissue, because there is a refractive table 10 to 15 micron. So that will be additional. So if you are ablating 1 diopter, correcting 1 to 2 diopter, it will be ablating 10 to 15 micron more than compared to the excimer. But in cases of high myopia, it will be the same what
Yeah.
sir is saying.
So for 1 or 2 diopters, I feel usually we have sufficient cornea where you can spare 10 to 15 micron extra. So, and that is just for the surgical safety. When you add on the 10 micron over that, the lenticule become to handle. When you want to dissect 2 layers separately, you want to have sufficient kind of thickness into the lenticule. Like means minimum 30 micron should be there in the lenticule to remove that lenticule as a separate layer for the anterior surface and the posterior surface. Otherwise, it may actually puncture or you can tear the thing. So that is. No, we usually use 6. 6.5 is actually not required with the lenticular extraction, which was there with the LASIK removal, because the effective optical zone in LASIK is reduced than what you feed in computer, and in here it is actual. It is actual. So that is the advantage. Yeah.
So sir, have you stopped doing surface ablation or you still
No,
do?
I have not stopped because there are many patients who go in military from Rajasthan.
Yes, yes.
So the surface ablation is the thing.
And in borderline corneas where there is suspicious
For
topography, you
borderline
should always
corneas,
do
I
surface
have my own
ablation. Yes.
reservation that whenever you are in doubt, don't treat.
Surface ablation is much safer in case the patient has a job aspiration and he
No,
is in-
job aspiration
yes.
is a big reason, and
So
I
in
agree
those
with you, when
cases-
there are some thin corneas, you can
Yes,
do.
you can do
But
surface ablation.
don't do LASIK or any refractive surgery
Yes.
when you feel the cornea is in doubt.
Yes, yes.
Thickness is
So
not in doubt.
creating a flap will weaken the cornea more than doing surface ablation.
Yeah. For this, I will add on just that LASIK, you create a full flap, means almost out of 360 degrees, 320 or 330 degrees cut. So all the surfaces are cut. In SMILE with the reverse, you just cut it.
So, but again, the cap doesn't give support
I understand
to
that
the
still
residual
studies are
stromal,
there.
right? It is the
Already cleared off that the ectasia rate, whether we cut the cap or we dissect the lenticule, is virtually
it's the same. It's only the surface ablation which leaves you compact cornea.
So-
It's much safer to prevent post LASIK
So
ectasia.
for that, what I say, the people who believe that with the SMILE you can reduce the RST, you can't. The maintain the RST same like LASIK, then
Yes.
ectasia will not be there. Almost I am doing for 13 years, no ectasia. So I am happy to
But
convert
ectasia
it
has
to
been reported in lenticule based surgery.
No,
also.
it is reported.
Yes, yes,
I am
sir.
not saying. But reporting means there are foamoplastic cases and you do the LASIK, then you will have a problem. You do SMILE or LASIK, whatever you do, then you will have a problem.